Okay, let's unpack this one. You're hit with this sudden, really intense joint pain. Maybe it's your knee, maybe your wrist pops up, it feels fiery, it's swollen, and your first thought might be, is this gout?
Right.
But what if it's, the other crystal culprit, the one that sometimes gets mistaken for gout?
Exactly.
We're diving into pseudogout today, or the more formal name, calcium pyrophosphate deposition disease, CPPD.
Yeah, CPPD disease. And that mimicry you mentioned is spot on. The pain presentation can be remarkably similar to gout. But the actual cause, the type of crystal driving it, it's fundamentally different.
How's it weird?
Well, gout is urate crystals, right?
Right.
Needle-shaped. Pseudogout, that's all about calcium pyrophosphate crystals. They look different, rhomboid-shaped.
Okay, so different crystals, like telling quartz and diamond apart, you said earlier?
Pretty much. Both crystals, but very different makeup and behavior in the joint. Understanding that difference is key. That's why you hear CPPD disease used too. It emphasizes the crystal deposition itself.
Right. And where does this pseudogout tend to show up? Which joints?
It can be quite widespread, actually. Hands, wrists, elbows, shoulders, knees, ankles.
So quite a few possibilities.
Definitely. And the tricky part is, if it becomes a chronic thing, it can really look like osteoarthritis, just wear and tear.
Or even rheumatoid arthritis.
Or even RA, yeah, which really underlines why getting that accurate diagnosis is so crucial. You don't want to be treating the wrong condition.
Absolutely. So think of this deep dive as like your roadmap through pseudogout. Our mission here, using the info we've got, is to give you a really clear picture of it.
We'll cover what it is, what causes it, who's most at risk.
What's actually happening inside the joint.
Exactly. How it's diagnosed, how it's managed, and sort of the long-term outlook.
Okay, let's start with the basics then. The definition. Crystal clear, hopefully. What is pseudogout?
Okay, so at its core, pseudogout happens because these calcium pyrophosphate dihydrate crystals build up in the synovium.
The joint lining.
The joint lining, yeah. The tissue that makes the lubricating fluid.
Mm-hmm.
And this buildup, it's not quiet, it kicks off inflammation.
Which causes the symptoms.
Precisely. That sudden, often pretty severe pain, the swelling, the redness, the warmth around the joint, those are the hallmarks.
And just to stress again, this is not gout.
Definitely not gout. Different crystal, different process.
Got it. So that's the what. Let's get into the why. What actually causes these calcium crystals to, precipitate out in the joints?
Well, the fundamental cause is the deposition of those calcium pyrophosphate crystals.
Mm-hmm.
But why they deposit in some people and not others, that's the complex part. There seem to be several factors that can precipitate an attack or make deposition more likely.
Like what?
Things like dehydration can play a role, changes the fluid balance in the joint. Having another illness at the same time, like an infection or even having surgery.
An intercurrent illness?
Exactly. That can sometimes trigger an acute flare. And then there are specific underlying metabolic disorders or medical conditions.
Ah, okay. Which ones should we know about?
The big ones linked to CPPD are hyperparathyroidism, too much parathyroid hormone affecting calcium, hypothyroidism and underactive thyroid, and hemochromatosis, that's iron overload.
So those conditions kind of change the joint's internal chemistry, making crystal formation easier.
That seems to be the idea, yeah. They create a more favorable environment for those crystals to form and deposit.
Okay, that makes sense. So we know potential triggers, but who is generally more susceptible? What are the main risk factors?
The biggest single risk factor, honestly, is just getting older, increasing age.
It just becomes more common as we age.
Significantly more common, yes. It seems the likelihood of these crystals forming just goes up over time. Family history can also play a part, suggesting a genetic link in some cases.
Any others?
Yeah, having had previous trauma to a joint, like a significant injury or even joint surgery, that seems to increase the risk in that specific joint later on.
And other joint diseases, like OA or RA.
Exactly. Having underlying osteoarthritis or rheumatoid arthritis also seems to make you a bit more prone to developing pseudogout on top of it.
Now, you mentioned younger patients under 60. You said that's a bit different.
That's a really important point, yeah. If someone under 60 develops pseudogout, it should really ring alarm bells about a potential underlying metabolic cause.
So you'd investigate more thoroughly.
Definitely. In younger patients, you'd strongly suspect conditions like hemochromatosis, hyperparathyroidism, but also things like low magnesium hypomagnesaemia, low phosphate levels, hypophosphatasia, even rarer things like acromegaly, which is excess growth hormone, or Wilson's disease involving copper.
So pseudogout in a younger person could be like a signpost pointing to one of these other conditions.
Precisely. It often warrants a deeper dive to find that underlying issue, which might itself need treatment.
Gotcha. Okay, so the crystals deposit in the joint space. What actually happens then, like at the cellular level, to cause all that pain and swelling?
Imagine these little rhomboid crystals just sitting there in the joint lining, the synovium. They act as irritants.
Like grit in the works.
Kinda, yeah.
Hmm.
Their presence triggers the body's immune system. You get an inflammatory response, white blood cells rush in.
The cavalry arrives.
Right, but their response is the problem in this case. That inflammation is what directly causes the pain, the swelling, the redness, the heat, all the classic signs of an acute attack.
And long term, does it damage the joint?
Unfortunately, yes.
Oh.
Over time, the repeated inflammation and the physical presence of these crystals can gradually damage the joint structures, particularly the cartilage.
Leading to more chronic problems.
Potentially, yes.
Yeah.
It can contribute to joint degeneration.
Okay. Now, we know it mimics other things. How do doctors actually sort this out? What's the differential diagnosis?
Yeah, differentiating is key. Top of the list of mimics is acute gout, obviously, because the symptoms could be so similar.
Right.
Septic arthritis, a joint infection, is crucial to rule out urgently because that needs immediate antibiotics. It's an emergency.
Absolutely critical.
Then you got the chronic conditions that can resemble, like osteoarthritis, especially the inflammatory flares pseudogout can cause within OA. And rheumatoid arthritis, particularly those rarer chronic inflammatory forms of pseudogout.
And other crystal problems.
Yes, there are other types of crystal arthropathy, like basic calcium phosphate deposition disease, sometimes called hydroxyapatite crystal deposition. Different crystal, again.
So careful investigation is needed.
Absolutely. You need to be systematic.
How common is this condition overall? What's the epidemiology look like?
It's actually pretty common, especially as people get older. We already mentioned age is the big risk factor.
And it affects men and women equally.
Roughly equally, yes. The prevalence really takes off after age 60. It's hard to pin down exact numbers for symptomatic disease. But some studies suggest that by age 80, maybe up to half of adults might show radiographic signs of chondrocalcinosis on X-ray.
Even if they don't have symptoms?
Even if they're asymptomatic, yeah.
Yeah.
For actual symptomatic pseudogout in people over 60, estimates are around maybe 7 to 10%.
Okay, so quite significant in the older population.
Definitely. And we mentioned familial cases earlier. Those are sometimes linked to mutations in a gene called ANKH.
Right. So let's picture a patient walking in. What's the classic clinical presentation? What signs and symptoms make you think pseudogout?
The absolute hallmark is that sudden, acute onset, often waking up with a really painful, swollen, red, warm joint.
And the knee is the most common site.
The knee is definitely the poster child for pseudogout. You know, maybe remember K for knee. But wrists, ankles, shoulders, hips, they're definitely possibilities too.
And these attacks, they come and go.
They tend to be episodic, yeah. They can recur, and an attack might last days or even weeks if untreated.
And when thinking about diagnosis, you'd consider those risk factors we talked about.
Absolutely. You're looking at the whole picture: age, any family history, prior joint injury or surgery, and screening for those underlying metabolic conditions: hyperparathyroidism, Haemochromatosis, low magnesium, low phosphate. Maybe FJAMH is a quick mental checklist. Family, joint injury, age, metabolic, like Haemochromatosis, hyperpara.
FJAMH, got it. What about specific physical exam findings?
On examination, you'll typically find a tender joint, often with obvious swelling and effusion. It might feel warm compared to the other side and look red.
Okay.
Sometimes someone with known osteoarthritis might just present with a sudden marked worsening of their usual symptoms, which could be a pseudogout flare on top.
And anything specific about older patients?
Yeah, sometimes in the elderly, the presentation can be a bit more vague, maybe more generalized malaise, perhaps even a low-grade fever alongside the joint pain.
So less localized sometimes.
Can be. But the classic sites are still knee, wrist, shoulder. The definitive finding, though, if you can get it, is aspirating fluid from the joint.
And looking under the microscope.
Exactly. Seeing those characteristic rhomboid-shaped crystals. Maybe you think rhomboid reminds you of rock, these tiny crystal rocks.
Rhomboid rock, okay. And x-rays.
X-rays are really helpful, too. You're looking for chondrocalcinosis. That's calcium deposition of the cartilage. It shows up as these linear white lines, especially visible in the knee menisci or the articular cartilage itself. Remember, C for chondrocalcinosis, C for cartilage calcium.
Cartilage calcium. Nice. But you said earlier lots of people have that on x-ray without symptoms.
That's a crucial point. Many, many people have radiographic chondrocalcinosis and are completely asymptomatic. It doesn't automatically mean they have or will get pseudogout attacks.
Interesting. So describe an acute attack again.
Okay, acute attack. Typically sudden onset, usually one joint, monoarticular, or maybe a few, oligoarticular. Knee and wrist are very common. Can sometimes have systemic features like fever. Untreated can last weeks, maybe even months.
And the chronic forms?
Chronic CPPD can be trickier. It might look a lot like osteoarthritis, but with more inflammatory flares than you'd expect. It can also affect joints not typically hit hard by primary OA, like the wrist or shoulder.
And the RA mimic.
That's rarer. But you can get a chronic inflammatory picture that really resembles rheumatoid arthritis, with persistent swelling and inflammation in multiple joints, both large and small.
Okay, so clinical picture points towards pseudogout. What investigations are needed to really nail the diagnosis?
The absolute gold standard, the definitive test, is analyzing the synovial fluid from the affected joint. Joint aspiration.
Why is that so key?
Because it lets you directly visualize the crystals. You can confirm they are calcium pyrophosphate rhomboid-shaped, weakly positively birefringent under polarized light, and crucially, it allows you to rule out septic arthritis by looking for bacteria and checking cell counts, and gout, where you'd see needle-shaped, negatively birefringent urate crystals.
So it confirms pseudogout and rules out the main dangerous mimics.
Exactly. It's indispensable, really.
What about x-rays again? Beyond chondrocalcinosis?
X-rays of the affected joint are still very useful. Besides showing the chondrocalcinosis, they might also show joint space narrowing or other changes that look like quite severe osteoarthritis, sometimes more advanced than you'd expect for the patient's age.
And blood tests. Are they diagnostic for pseudogout itself?
Not directly for pseudogout, no. There's no blood test for pseudogout. But blood tests are vital for checking for those underlying metabolic conditions we keep mentioning, especially in younger patients or if the presentation is atypical.
So checking calcium, parathyroid hormone.
Yep. Serum calcium, parathyroid hormone, iron studies for hemochromatosis, alkaline phosphatase for hypophosphatasia, serum magnesium for hypomagnesaemia, looking for those treatable root causes.
Any other imaging techniques used?
Ultrasound is becoming increasingly popular. It's quite good at visualizing crystal deposits on the surface of cartilage, sometimes even better than X-ray for detecting chondrocalcinosis. There are also more advanced techniques like dual-energy CT, which can help differentiate crystal types, and even things like diffraction-enhanced synchrotron imaging, but those are more research tools currently.
Okay. Let's dive a bit deeper into that joint fluid analysis. What specifics are you looking for besides the crystals?
So, when you analyze the fluid, you typically see an elevated white blood cell count indicating inflammation, right? It's mostly neutrophils.
Okay.
The glucose level in the fluid is usually normal, which helps distinguish it from septic arthritis, where the bacteria consume glucose, making it low. And then the star of the show, those rhomboid, weakly, positively birefringent crystals. Seeing them inside the white cell's intracellular crystals is particularly suggestive of an acute attack.
And the appearance of the fluid itself?
It can sometimes look quite cloudy, even pus-like or purulent, which again can be misleading and really emphasizes why you must do the gram stain and culture to definitively rule out infection, even if you see crystals.
Always rule out septic arthritis first.
Always. So the overall approach is analyze the fluid for crystals and infection, use imaging like X-ray or ultrasound, do blood tests to check for underlying causes, and exclude other forms of arthritis.
Right, comprehensive approach. So you've got the diagnosis. How do we manage pseudogout? What's the treatment strategy?
The main goals are symptom control, relieving pain, and reducing that inflammation, particularly during those acute flares.
Okay, so for an acute attack.
First-line options are usually NSAIDs, non-steroidal anti-inflammatory drugs. Things like naproxen, diclofenac, indomethacin can work well. Paracetamol can help with pain but doesn't hit the inflammation as hard.
What if NSAIDs aren't suitable, or the pain is really bad in just one joint?
Then intra-articular corticosteroid injections are a great option. Injecting the steroid directly into the affected joint can give very rapid and effective relief, especially if it's just one or maybe two joints flaring up. Think I for intra-articular, I for intense, isolated inflammation.
Makes sense.
And resting the joint during the flare is important too.
What about colchicine, often used in gout?
Colchicine can be used for acute pseudogout attacks as well. It's often considered if NSAIDs or JANE injections aren't appropriate or haven't worked, it helps reduce inflammation.
And systemic steroids, like tablets.
Oral corticosteroids, yeah. They might be used for more severe attacks, especially if multiple joints are involved, a polyarticular, or if other treatments fail or are contraindicated, usually just a short course.
Are there non-drug things people can do during a flare?
Definitely. Simple things like applying ice packs to the joint can really help reduce swelling and numb the pain.
Good old ice.
Yep. And sometimes splinting the joint to rest it can be beneficial too. And as we mentioned, just aspirating the fluid out of a very swollen, tense joint can provide immediate relief by reducing the pressure.
Okay. Now, are there any medications to actually prevent attacks from happening, like we sometimes use for gout?
That's a key difference. Currently, there are no established, routine medications specifically proven to prevent pseudogout attacks or get rid of the crystals long term.
So no equivalent to allopurinol for gout?
Not really, no. There's no specific treatment aimed at dissolving or eliminating the calcium pyrophosphate crystals themselves. Management is really focused on treating the symptoms when they occur.
So it's tailored to the patient?
Very much so. It depends on the severity, which joints are affected, how frequent the attacks are, and crucially, the patient's other health issues, their comorbidities.
So quick recap of acute attack treatment options.
Ice, joint aspiration for relief, NSAIDs, intra-articular steroid injection, potentially colchicine, or systemic steroids for severe cases.
Right. What about managing the more chronic forms of pseudogout? You said that can be tough.
It can be challenging, yes.
Yeah.
If someone has persistent inflammation in just one or a couple of large joints, repeating those intra-articular steroid injections periodically can be helpful.
But no disease-modifying drugs.
No specific DRs licensed for CPPD, unfortunately.
Mm-hmm.
Some people try low-dose colchicine or low-dose NSAIDs daily as a preventative measure, trying to reduce the frequency of flares, but the evidence is a bit limited.
And if those don't work or cause side effects?
Low-dose oral steroids might be considered as a last resort for chronic inflammation, but obviously you have to weigh the long-term risks of steroid use.
And if someone has pseudogout and osteoarthritis in the same joint?
Then you manage the osteoarthritis according to standard OA guidelines, physiotherapy, exercise, weight management, pain relief, alongside managing any acute pseudogout flares.
Okay. What about the long-term outlook? What's the prognosis for someone with pseudogout?
Generally, it's considered a chronic condition. It tends to stick around. But the good news is that with effective management of the flares, most people can control their symptoms reasonably well and maintain a decent quality of life.
How quickly do attacks resolve?
Acute attacks usually get better within about 10 days or so, especially with treatment, although some can grumble on for longer.
Is there a risk of joints getting permanently damaged?
Yes, that is a potential long-term consequence. Progressive joint damage can occur in some individuals, leading to functional limitations. The overall prognosis really depends on the frequency and severity of attacks, which joints are involved, and importantly, whether there's an underlying metabolic condition that needs managing.
Are there specific complications to be aware of?
The main long-term complication is the progressive joint damage we mentioned, potentially leading to deformity and loss of function, essentially a severe form of secondary osteoarthritis.
Any rarer issues?
Less commonly, you can see things like calcification in the soft tissues around the joints, like tendons or ligaments. Bursitis can occur, but the joint damage is the primary concern.
So regular follow-up is important.
Yes, regular monitoring and sticking to the management plan is key to try and minimize those long-term complications.
Okay, that was a really thorough exploration. Let's just quickly pull out the absolute key takeaways on pseudogout.
Sure. So remember, pseudogout, or CPPD disease, is arthritis caused by calcium pyrophosphate crystals, different from gout's urate crystals.
Key difference.
Presents typically with sudden, intense joint inflammation. The knee is the classic joint, but others can be affected. Diagnosis hinges on finding those rhomboid, positively birefringent crystals in joint fluid.
The rhomboid rocks.
Exactly. And look for chondrocalcinosis, the cartilage calcium on X-ray. Always consider underlying metabolic causes, especially if the patient is under 60.
FJAMH risk factors.
Right. And management is mainly symptomatic for acute flares, NSAIDs, joint injections, colchicine, sometimes steroids. No cure or specific prevention currently.
Excellent summary. And if you, listening, want to really cement your knowledge on conditions like pseudogout, especially if you're prepping for the MSRA exam, definitely check out passthemsra.com.
They've got loads of comprehensive resources. And for more free revision materials, question banks, and helpful content, freemsra.com is another great place to look.
So wrapping up, pseudogout really shows us how complex joint pain can be, doesn't it? It looks like one thing acts like another sometimes.
Definitely.
It underscores why getting that specific diagnosis, understanding the crystal involved, looking for underlying causes is so vital for managing it effectively. A good reminder that not all joint pain is the same.